Very happy that you're here and thanks for inviting me to do this presentation. I'll just share my screen.
Mm.
Are you all able to see my screen?
Yeah.
Okay. Um, so a very warm welcome to all of those who are attending this webinar on Sneeze to Wheeze, the burden of allergy and asthma. As has been mentioned, I'm an allergist, immunologist, and an asthma specialist. I've been in practice for about 23 years now. 10 of them were in America, or 11, and around 12 in India now, based in Mumbai. And we're going to go on this journey to understand what are allergies, what is allergic asthma, uh, how much of a problem is this both for the people who are suffering as well as the people who are taking care of these patients, and how we have to deal with this in today's day and age, and what are the gaps that need to be filled. So, when we think of our immune system, we truly have an amazing and incredible immune system, which is what drove me to the field of allergy immunology, because I was fascinated by it when I was studying it in our microbiology section in our second year of MBBS. That this is such a phenomenal system that can differentiate self from non self down to the tiniest little cancer cell that might be forming in the body, and be able to remove it by recognizing that this is not ourself, and then how this leads to tolerance versus intolerance to our environment or to things within our body, and hence leads to disease, either allergic or autoimmune, and many other things that we know of. When we think of allergy, this is derived from the word called allos and ergos. Allos means a different or changed, ergos means work or reaction. So this is an altered reaction or a changed reaction. And allergies, really, in the true sense, are an abnormal reaction of the immune system to harmless and innocuous things in our environment. Now, those things could be pollen, those things could be the food we eat, those things could be the medicines we take, those things could be anything else that we are exposed to. And literally, we are exposed to thousands of proteins and glycoproteins in our day to day life every single day. And even one error where the immune system makes an overzealous, overactive response can be self damaging. And this is a sign of a failed immune balance, or what we call a immune dysregulation. The key mediating antibody when we think about allergies is this antibody we call IgE. You all must have all during COVID heard a lot about IgG, which is actually a tolerant antibody, and you must have heard of IgM, which is the first antibody that responds whenever we get an infection or get any kind of exposure, whether it be viral, bacterial, fungal. And subsequent to that, there's also IgA, which is on all our secretory mucous membranes, nose, mouth, lungs, digestive system. And IgE is a very unique antibody in the sense that it helps us fight parasites and certain other viruses and certain other infections. But when this IgE gets directed against things that it should not fight against, that's when we develop allergies. And when these allergies get really severe, they can lead to anaphylaxis, which is a life threatening allergic reaction. And every year, thousands of people across the globe die from allergic reactions to drugs, allergic reactions to insect stings, allergic reactions to foods. And so, truly, this problem is not something that is mild or minor, it can get very, very serious. Why is this a major problem? Because in the last 5 decades, allergies have been progressively getting more problematic around the world. Some of the countries like United States, United Kingdom, Australia have kind of peaked in how far their allergies have gone, and they were the world leaders in allergies. But India caught up in the last 2 or 3 decades, and now has a very rapidly growing population. So the world population, about 30% people have some allergic condition or the other. In Indian population, already it's an estimate of around 20% with studies done in north, west, east, south, all parts of the country, central India. These are the statistics that come out. And a high proportion of these people are young individuals. So as they grow older, these allergies don't go away. They're chronic problems in many cases, and they can increase the burden of allergy in our society and amongst our people. Behind this is the westernization of our.
Dr. Roy?
Yes, yes. Somebody say something. Hello. So an estimated 30% of the world population is affected by one or more allergic conditions, and in India, the estimate is around 20%. High proportion are young individuals, children, very, very young, begin with allergies. I'll go through that in the next slide. Our westernization of our diet and lifestyle is a huge part of why allergies are increasing. And when we look at the world statistics, we can see that in a country of almost 1.4 billion or so, if you take 20% of the population, we are talking about over 30 crore people suffering from at least one allergic disease. Next slide. Conservatively, as I said, about 30 crore people, high demand. And when we look at the broad scope of allergies, and this is a very important slide because people think allergies means nasal allergies, allergies means skin allergies. It's a lot more than that. So atopic dermatitis or allergic eczema, this starts it can start on day 1 or 2 of life. Literally, I've seen 15-day-old babies covered in eczema. So it's a skin allergy, very often driven by environmental or food allergens. Nasal allergies affect about 50 crores. Asthma affects around 30 crores around the world. Ocular allergies, eye allergies, allergic conjunctivitis, what we call. Food allergies, about 15 crores worldwide. Drug allergies, medication allergies. Insect sting allergies, which can be a huge problem and even be life threatening. Anaphylaxis, which is your serious allergic reaction, as I discussed. Allergic contact dermatitis, so allergic reactions to wearing artificial jewelry, allergic reactions to hair dyes, to cosmetics, to soaps. The list is endless of what a immune system can become hyperreactive to. Acute and chronic urticaria, which is hives, rashes, itchy rashes, swelling coming up on the face, lips, eyelids. These are all in one way or the other related to the allergy and the immune system. And then eosinophilic disorders of the skin, gut, and respiratory tract. And there are a lot of things in our environment that the immune system can erroneously start fighting against and lead to an allergy. Next slide. Can we have the next slide, please?
Yeah.
So, a family that has allergies has a higher risk of having another family member with allergies. If no member has allergies, the risk, as I said, can be up to 20%. If there's one sibling, one brother or sister who has allergies, the other brother or sister can have a risk of 25 to 35%. If there's one parent, similar 20 to 40%. If both parents have allergies, the risk can go up to 70%. And if both parents have the same type of allergy. So if both of them have nasal allergies, that risk can go up to 80% in their offsprings in their children. So there is a genetic component, but recognize there is new onset allergy, and we are seeing a ton of it in India. Every single day in my practice, I get people who have never had a family member with any allergy that they know of. Maybe some of them were undiagnosed or unknown, but clearly they are having what we call de novo new onset allergies. Next slide. The economic burden is huge. We have data from all these countries: Australia, Finland, South Korea, Israel, Mexico, USA. You can see just in the US, about 19.7 billion yearly costs, which are the costs for asthma and allergic rhinitis, up to 20 billion. Remember, there are direct costs from the person being sick themselves, the amount of medications they have to take, the healthcare system that they have to use, and indirect costs. They can't go to school. If the kid doesn't go to school, the parents can't go to work. Uh, Adults who are sick can't go to work, can't be productive. All of this, when you add up, the list goes very long. And this is data that's kind of old now. This is data from 2011-12. These numbers are even higher now. It's a huge problem worldwide and certainly in India too. Next slide. When we look at the roots of allergic reactions, they can occur from skin contact, from getting injected with it, like a bee stinging or a wasp stinging, to medications being injected. It can be ingested, taken by mouth. So, medications, foods, drugs again. Inhalation, you talk about pollen, house dust mites, animal dander, molds. The list is very, very long of what we get exposed to. Next slide. Now, this is a very important slide because the word allergy is very loosely used by people. You hear anyone and everyone saying, I'm allergic to this thing, I'm allergic to that thing. In fact, studies have been done where people have been asked about allergies, and about 20 to 25% of them felt they were allergic to some food or food additive or food coloring or food preservative. But when they were allergy skin testing that subsequently had what is called a challenge done, an oral challenge where the food was fed to them in a blinded manner where they didn't know, so they can't have a psychological reaction to the food. It's called a double blind placebo control exposure to the food. Actually, only 2% of them had an IgE mediated allergy, which means almost, you could say, 18% of those of that population were overestimating their food allergies. So remember that there's food intolerance, there is food sensitivity, there are many other things. There is something that you all might have commonly heard of as lactose intolerance, where a person drinks milk and they get gassy, bloated, nauseated, they can have loose stools, diarrhea. That's not an allergy, that is an enzyme deficiency because of which lactose, which is the sugar molecule in milk, can't be digested. And as a result, the person feels every time they have milk products, they have problems and they label themselves as milk allergic. That's an error. Similarly, this can happen with a lot of different foods, a lot of different environmental antigens, a lot of different contact substances that we come in contact with. Also, on the other hand, you look at all those people who get recurrent cold, recurrent cough, with or without fever. They keep seeing it's a normal infection, they keep getting antibiotics, they keep getting short courses of antihistamines. In reality, it is allergies and they never get tested, they never get diagnosed, they never get treated properly. So allergies are significantly underdiagnosed for sure, and they are overestimated by people on their own without ever getting tested. Next slide. The perceptions about allergies amongst patients, doctors, patients find them bothersome, energy draining. Doctors do episodic treatment, disease management. Patients feel it's mostly unimportant, not significant in the big picture. And finally, many just live with it for their entire life, when in reality, these can be life altering. Next slide. Common allergen groups that we think about: food allergens, which are ingested. They can also come through inhalation route. So I have patients, if they walk into a seafood restaurant, they will get an anaphylaxis just with seafood being cooked in the back of the kitchen. But mostly it is through ingestion by consumption through mouth. Aeroallergens, house dust mites is the number one allergen in India. It's also a very common allergen in the entire world, every country, every place. They've been living around us since thousands of years, but some people's immune system sees their feces and their body parts as as enemies and reacts to them very badly. Pollen, which can come from trees, grasses, weeds, in different seasons, can lead to very bad nasal, nose, and ocular eye allergies in people. Cockroach, other insects, animal dander, cats, dogs, hamsters, rabbits, gerbils, you name them, molds. These are all common allergens that we get exposed to. Remember that the cigarette smoke, that's an irritant. Smoke from agarbatti, dhoop, mosquito coils, these are irritants. They're just as bad, but they're not allergens. Okay, they don't incite an immune reaction, they incite an irritant reaction. Construction dust, I keep getting people telling me I'm allergic to construction dust. They could be allergic to some ingredients in it, but that's not the primary problem. An allergy is a very different. So if you see a blood test for allergy that measures allergy to cement or to concrete or to limestone, understand that that's a bogus allergy test. That's not a real allergy test. Those are chemicals. You can't develop IgE to them. Next slide. We'll briefly talk about allergic rhinitis. As we know, this is nasal allergies. The typical symptoms are sneezing, runny nose, itchy nose, blocked nose, congested nose. Some people may have one of these four symptoms. Someone might have all four. It is totally unpredictable. There are some people who are more what are called runners. They have more runny nose, and there are others who are blockers, who have more blocked nose and never sneeze or have a runny nose. So allergies are very weird and they vary from person to person. Allergic rhinitis again occurs due to induction of an IgE mediated allergic reaction to something in the environment, which then on repeated exposure gives symptoms every time it's exposed. So I have patients with house dust mite allergy. Every morning they'll wake up and they sneeze 10, 15, 20, 50, 100 times before they finally stop sneezing and can begin their day. But by then they are fatigued, they are tired, they are irritable and everything else. Obviously, this is a severe case. Allergies can be mild or moderate to severe. They can be seasonal, they can be perennial, which is year round. And all of those are classifications. Again, it's a rising prevalence. 15% of the population in our country potentially has allergies. Next slide. Now you would think that that's something that you can pop an anti-allergic pill and get away with. Well, it's way worse than that. So people with allergies can also have comorbidities of allergic eye conditions. They can develop sinusitis, they can develop ear infections, they can develop recurrent respiratory infections. So they are more prone to catch every virus and every bacteria that comes around. They can end up having a decreased quality of life. Their sleep can be affected. They can be snoring loudly at night. They can be mouth breathing. If they mouth breathing, they can have bad breath, bad odor to breath. They can have bad dental health, cavities, gum diseases because their mouth gets dry from mouth breathing. The kids can have dental malocclusion and then require lakhs of rupees worth of orthodontic treatment when they get older. Learning and attention impairment, sleeping disorders. The list is so long just from simple nasal allergies. So you can imagine this can also lead to anxiety, stress. I've had patients in severe depression come to me. Finally, someone figured out that their allergies was bothering them. They were on 3 or 4 antidepressant drugs, not getting better. We identified their allergies, gave them the right treatment. They came off all their antidepressant drugs. So you can only imagine. I've had so many cases in my life where patients have come and said, Dr. Roy, you're our last hope. If you can't help us, we are seriously going to commit suicide. So when I talk to people about allergies, I always tell them don't take them lightly. Next slide. Asthma, which can be both allergic and non-allergic. Remember, nasal symptoms can also be allergic or non-allergic. Non-allergic rhinitis is also a very well-known category, and that can be due to many reasons. We can't go over it today. Asthma is a chronic inflammatory disease of the airway. So we are talking about the bronchi in our lungs and the smaller air tubes, which are called the bronchioles, all the way into what is called the 21st or 25th generation of division in our airway. Remember, our lung is like a tree with many branches, and the leaves at the end are the alveoli where the air exchange occurs. And asthma is a disease of the airways. These airways become twitchy. Because they become twitchy, a person coughs, wheezes, gets short of breath, gets tightness in the chest. Sometimes they can have chest pain. If this problem progresses, they can even end up with atelectasis, which is blocked areas in the lungs. They can end up with pneumonias, which can be super infected with viruses or bacteria. It's estimated about 2 crore Indians have adults, I'm talking about, have asthma. You can assume that up to 75% of them are never properly diagnosed. Maybe 20, 25% have a diagnosis. Out of those 20, 25%, probably 15 to 20% are not taking medications properly. So it's a very poorly managed and treated disease. In kids, these numbers can go up to 10%. Okay, it's a very high number. In the younger kids, wheezing is a very common problem. I always say when I was in training as a medical student, it's been a long time, 30 years ago, there used to be two or three kids on a nebulizer in the ward in winter or in monsoon. And now, if I go into any of the public teaching hospitals in Mumbai, more than half the ward is filled with wheezing children during the monsoons or winter months. Huge problems, increasingly getting worse. Asthma can be intermittent, which means people can be totally fine between episodes. It can be mild, where there is impact on their daily activities, on their requirement for inhalers. It can be moderate or it can be severe. Severe is almost daily symptoms, ongoing basis, day, night with exercise. Next slide. When we look at the pathophysiology of asthma, we realize asthma is not one disease. In India, it's called dama for everyone. Dama means a person who's breathless, they're with an inhaler, and asthma is not like that. Asthma can present just with a cough. I have so many patients with cough variant asthma, nothing but coughing. Okay, they never wheeze, they never get breathless, they never get short of breath. Even when they exercise, if the asthma is to act up, they'll just be coughing. What we have to realize is that asthma has many different phenotypes, many different presentations, and it also has many different endotypes. Endotypes means the cause why it's happening. So there's eosinophilic asthma, there's non-eosinophilic asthma, there's neutrophilic asthma, there is paucicellular asthma, there is T1 type of asthma, there's T2 type of asthma, so allergic, non-allergic asthma. And we really know a lot more about this disease than we did probably 30 or 35 years ago. What we have to also recognize is that 60% of adults who have asthma have allergic asthma, and about 85% of children who have asthma have allergic asthma. So allergies play a very big role in asthma, along with everything else, right from the person's emotional upheaval, crying a lot, laughing a lot, being sad or depressed can make asthma worse, to dust, pollutants, diesel particles. The list is endless. Ozone, nitrogen dioxide, sulfur dioxide, other kind of indoor and outdoor pollutants can all make asthma worse. So it's a really multifactorial disease that really needs a very different way of management. Next slide. So in allergy or asthma diagnosis, it is history. So it's not just his story, it's also her story. Clinical examination, which may be totally normal between episodes. So just having a normal lung examination doesn't mean the person doesn't have asthma. And then there are investigations like spirometry, pulmonary function testing, also called lung function testing, airway oscillometry, a very new introduction in the last couple of years in India, fractional exhaled nitric oxide, which measures a gas called nitric oxide, which is elevated in allergic asthma, especially complete blood count, a serum total Ig, which gives us an indication could this person be allergic or not. But a normal total Ig does not rule out allergies. You can have a normal total Ig and still be allergic. And then imaging studies like X-rays and CT scan, which is only required in selected cases. Next slide. Next slide, diagnostics very briefly. Uh, so history, examination, and then allergy skin testing. That's the way for our contact allergies like poison ivy, poison oak, contact to metals, nickel allergy, hair dye allergy. There's something called patch testing, which is shown in the lower edge. Then there are food challenges that we do. Next slide. Skin prick testing or allergy skin testing. This is still the gold standard, where we introduce a tiny amount of the allergen under the skin, and within 15 minutes, we will know if the person is having something called a wheal and flare reaction, where the skin gets red, raised, itchy, and we measure those and we can know what kind of allergies the person has. And we can do this for 5 or 10 allergens. We can do this for 50 or 60 allergens. A good allergist will generally test for no more than 60 or 70 allergens. There are people who do for 200, 300. That's completely unnecessary according to the top allergists around the world. Next slide. The blood tests, these have really advanced for people who cannot do the allergy skin testing or don't have access to it. Remember, blood tests are relatively more expensive. They also cannot pick up the India-centric allergens. The Indian allergens like masoor dal, tur dal won't be there on these international panels. But they do give results with a single blood draw, and the most recent component resolved diagnostics require only 2 or 3 ml of blood to give about almost 293 results, of which about 95 are complete allergens, and the remaining are what we call sub-components of these allergens. Next slide. Very, very accurate tests, very, very useful. So early diagnosis of allergies is very important because with that you can do the right allergen avoidance. Allergen avoidance makes a difference. We know if someone is seriously allergic to a food and doesn't ever eat it, they will not die because it went into their body. So similarly, if you have dust mite allergies, there are things you can do with your mattress, pillow, bed environment, home environment. If you have a pet allergy, there are things you can do. If you have a cockroach allergy or a mouse allergy, you can do pest control and other things which can make a difference. And then there is something called immunotherapy, which I'll briefly talk about, by which you can desensitize the allergies. So, worldwide, recognizing the allergies, knowing that someone is suffering from it, giving them access to do allergy skin testing so that they can get diagnosed, and then providing the right treatment to them can literally change their productivity, their creativity, their life, their sleep, their everything. Okay, next slide. When we manage allergic diseases, obviously once we've identified what the person is allergic to, so just telling anyone who has allergies ki baba dust se dur raho is like telling each and every person to drink 4 liters of water every day. It doesn't make any sense. Someone may get away with 1.5, someone may need 2.5. Varies from body to body. So allergen avoidance has to be specific to what the person is allergic to, not generic. Then there's patient education. People forget that allergies are chronic diseases. Asthma is a chronic disease. They need to know what to take on a regular basis, what to do when they flare up, what to do, when to see the doctor, when to go to a hospital or an emergency room, what to do if they have food allergies or insect sting allergies, if they get stung or consume that. There's something called asthma action plans. There's something called food anaphylaxis management plans. Patient education is a very, very critical part. I have all my nurses in my clinic are trained to do this, right from the technique with the nasal spray that they may use or the inhaler they may use, all the way to how they are supposed to escalate or downgrade their treatment under the doctor's guidance. Everything comes under patient education. Then there's pharmacotherapy, the medications that we give, the tablets, the nasal sprays, the syrups, the inhalers, the dry powder inhalers, the MDIs with spacers, right dose, right time, when they get better, reduce, taper, don't stop. Only after the person has been well, if they go into remission, can you stop, which takes months or years. And then immunotherapy to desensitize the person effectively from the allergy, done by a super specialist in allergy. Next slide. So allergen immunotherapy has been around since 1911. It can be done in the injectable or the oral form. It leads to significant reduction in symptoms of allergies within 6 months to 1 year. It is steroid sparing, so nasal steroids, inhaled steroids, which are typically used, reduction in those doses can be even stopped. Reduce flare-ups or exacerbations of allergies occur, the ability to alter the natural course. So if a child with nasal allergies gets put on immunotherapy, they may be prevented from developing allergic asthma, which they have a 40% chance of developing as they get older. And by doing immunotherapy at the right time in a child, it can be done in kids over 5 years of age very effectively. They are safe and efficacious. They can cause allergic reactions, but if they're in the hands of a trained allergist immunologist, it's very, very safe and very effective. Next slide. That's injectable or subcutaneous immunotherapy for you, given in the back of the arm, in the subcutaneous of the fatty tissue. Next slide. Sublingual immunotherapy is done as drops or as tablets under the tongue. taken once a day on an average, then gradually there are some spacing protocols, but it's done at home. The injectable immunotherapy is done in the doctor's office because the risk of reactions is higher in injectable immunotherapy than in sublingual immunotherapy. Problem is there are many people doing this incorrectly, just as there are many allergy tests which are bogus or fake or incorrectly done. These therapies are also being done as a way of generating cash without real focus on how, where, when it is being done. So we do need awareness about these things also being done correctly. Next slide. So as a closing slide, while allergies are rising worldwide and especially so in India, I have seen, I would say the estimate is around 200 to 300% increase in allergies in the last just 2 decades. With the right diagnostics and eventually with the right pharmacoimmunotherapeutics, it is possible to change the natural course of this disease and also make a huge difference to the life of not just the patient but their family members also. Remember, if one person snores, the entire house hears it. If one person falls sick with an asthma attack, the whole house is awake at night trying to get them to breathe well. If one person gets an anaphylaxis, a whole community can be disturbed and destroyed if they lose their life. So, uh, all of y'all who are hearing this, take this message. I thank you very much. I put out a lot of information on allergies on my YouTube channel. It's called Dr. Roy Health. I also put it out on LinkedIn at Dr. Sitesh Roy, and also on Instagram. I keep putting posts. So I welcome you all to join me, follow me there. If you're interested, get in touch with me. And I thank you all very much for attending today. And I look forward to any questions that might be there.
Thank you, Dr. Roy, for a valuable presentation on allergies. And if anybody wants to ask any questions, the platform is open for you all. Anyone? Dr. Bhavna ma'am, if you want to say anything.
Thank you so much again. Wonderful presentation, Dr. Roy.
Thank you.
My question is, I'm waiting for questions for others, but anyways, how about gut health? Means how gut health and allergies both connected?
So there is a very massive connection, as you very well know, and it's good for all the youngsters in the group to hear this. As I said, diet and lifestyle are the two reasons why allergies are increasing. When I spoke about diet, I said westernization of diet. Okay. In the Western diet, there is a lot of processed food, as we know. Okay. A lot of sugars, a lot of salt, a lot of refined flour, a lot of other things which are very unhealthy. We know that all of these foods ultimately go in and alter our gut microbiota, what we call our internal flora of our intestines, our stomach, our colon. And these bacteria, remember, our immune system goes through a training phase. So, our immune system, the cells are formed in infancy in our liver, spleen, and bone marrow. Later on, it all goes to the bone marrow. Every immune cell that comes out of the bone marrow goes to the lymph nodes. The lymph nodes are the largest number of lymph nodes are in our digestive system, in our gut. They are called Peyer's patches. That's where they get trained on how to interact with the outside world, because remember, our connection to the outside world is through our nose. Our nose is connected to our mouth and our throat. Everything we goes in our nose ultimately goes in our stomach, whether we like it or not. Everything that goes through the mouth goes in the stomach. So that's our exposure to the external world. And so the type of bacteria that are there in our stomach and intestines determine whether our immune system is going to be overreactive or it's going to be tolerant. So, gut health is extremely well connected and intensively connected, so much so that there are studies that if the baby or if the pregnant woman is given certain types of probiotics during pregnancy, her baby may have a lesser chance of developing atopic dermatitis, which I said allergic eczema is the first manifestation of allergy. There are also studies to show that if the baby is given probiotics early in life, we may prevent or reduce the chance of atopic dermatitis. We may also potentially reduce the chance of wheezing disorders, but the impact on allergic rhinitis and asthma is not yet very clear or obvious. There are intense studies going on. There are also studies on combining microbial substances along with allergens to do more effective immunotherapy. So the invisible world, the world of SARS-CoV-2 brought the entire world to its knees, okay, and put everything on hold. That same invisible world inside us dictates what our immune system is going to do. And I certainly have 3 diet counselors on my team. I work a lot with immune modulation through probiotics and diet. And I believe that that is the next frontier. Whether you talk about heart disease, you talk about kidney disease, you talk about diabetes, you talk about brain health, you talk about Alzheimer's, in every single disease, your microbiota, your gut flora has an immense role to play. Even if you're depressed, your gut flora is different than when you're happy and excited and living life to the fullest. So you can imagine that these bacteria have a crosstalk with our brain through a variety different mechanisms, cytokines, chemokines. There's also the vagus nerve that runs all the way from our brain stem to our first part of our intestine and the stomach. This crosstalk really determines who we are and what we are, not just what we do or how our health is, but literally who we are and what we are. And our ancient ways of eating in India were really the most advanced and the most phenomenal ways of taking care of our gut. We really need to wake up to it. The West has already woken up to it. They're talking about turmeric and curcumin and ginger and all the herbs, and about yoga and about pranayam and about everything else. I hope we Indians wake up to it. It's high time, and we should not let the West have to feed it to us before we start accepting it as real and true. So, a very important question. I know it was a long answer, but I knew that was gonna. I knew you knew that it would come that way.
Nicely answered, means everything you connected, and how this like asthma or all these allergic things have increased. You have mentioned that 200 to 300 times, and this is westernized diet, 100%. Yeah. One more term I really liked, this is de novo allergies. La? So like when person, there is no family history and but there is a condition like you had mentioned the term de novo. So would you like to explain this? That's what is that?
You can simply
I'm
call
not
it
finding.
new onset. You can simply call it
New
new onset
onset.
allergies.
Okay,
And
okay.
and these are new onset allergies which occur in a family. So neither the
Mhm.
parents or the grandparents or the siblings of the parents or their children or first degree blood relatives, nobody seems to have
Nobody
allergies.
is.
But
Yeah.
this person has developed allergies and they are sitting and scratching their head. How am I getting this when no one else has it? And this was very well studied in a multi-center trial that was done in Germany. There was a birth
Mhm.
cohort, so mothers were enrolled while they were pregnant. Babies were followed from the time they were born
Mhm.
till they were older, and what they found was 51%, very interestingly, of people, and remember, Germany has a very high prevalence of allergies to begin with.
Yes.
51% of the allergies they were seeing were new onset allergies. I would say probably in India the number is higher. And obviously in India the
Mhm.
diagnosis has been so poor. So even if the parents or grandparents had chronic rhinosinusitis, they just never got diagnosed. They just got treated with antibiotics and antihistamines and syrups and nasal sprays and otrivins. And they just went through life thinking that this is part of life. This is what I have to suffer with. Nobody ever
That's
did the
true.
test, nobody ever treated them, nobody did immunotherapy. So, but when we take the history, we have to go with what the patient tells us, and de novo allergies are basically new onset allergies.
Wonderful.
We're seeing a lot
Right.
of it, very young children. And it's interesting, if the parents developed allergies in their 20s or 30s, if the
Mhm.
grandparents developed allergies in their 40s and 50s, the third generation develops allergies in the first 2 years
Then
of life.
first
It's
was.
called gene penetrance. It gets worse and worse with each passing generation.
Yeah, very interesting. And one more study you mentioned, Dr. Zeroy, that is double-blind placebo exposure to allergen, where people are only 2% people were aware about. That was a right allergy, but we make our concepts like that, or some psychosomatic origin of that kind of some symptom. Na? That was
Correct.
also very interesting aspect of that.
True.
presentation.
So
Do
many, as I
we?
said, many people
Yeah,
believe they have allergies, but they don't actually have
yeah,
allergies. It
that
can be
was
a
interesting.
psychological reaction. It can be a chemical reaction to a food.
Chemical
It can
reaction.
be a toxic food. The food just got spoiled and they vomited and had diarrhea after eating it. Now they label
Mhm.
it as an allergy. So we see this all the
Allergy.
time. Yeah. Please go
Yeah,
on. Yeah.
like you mentioned, intolerances and sensitivity,
Food
and like
intolerance is
these
also
some,
there.
yeah,
Yeah. Yeah.
exactly.
They are IgG mediated in some cases, they are immune complex mediated in other cases. That's a very tricky part, no perfect test,
Tricky
very
part.
difficult to diagnose, but very much does occur in people.
Yeah. Any question, Ashish? You can find in
Yeah,
YouTube. So I can.
Dr. Ankur wants to ask one question. I'm
Mhm,
unmuting.
mhm. Yes, go ahead.
Sorry. Yes, Dr. Ankur.
Sir, excellent talk as always. My question is, we see a lot of time that patients of allergies are getting themselves tested more frequently with the blood test,
Mhm.
and then they come to us with the reports that the allergy test is showing me that I am allergic to potato and rice and milk, and I do not have any I used to eat all those things in the morning itself.
Correct.
So, how would you address such situations? How to counsel patients that this test is not correctly done, or and every allergy test should have a clinical association with the test. It's not that I have done some tests and I cannot explain it clinically to you.
Correct.
So how
So,
to counsel such things?
so there are two things that are very important to remember. The first thing that I tell my patients whenever I do allergy skin testing also, that a positive test is not equal to an allergy. A positive test only means that you have something called allergic sensitization, which means at some point your body may have made the IgE molecule against some of the proteins in that food. A clinical allergy is when you are exposed to that food and you get symptoms because of it. So there's a difference between sensitization and allergies. That's the first thing you have to explain to them. Okay. And they also have to realize that there are a lot of the next step is false positives. Okay. And especially in the cheaper tests, I can't name them because it can create hassles, but if you want to talk to me about it later, I will tell you. But there are tests in the country which are done by very senior physicians, general practitioners, consultant physicians, pediatricians, which are completely inappropriate tests, and they come back with 8, 10, 15, 20 things that are positive and they have no relevance to the person's history. So firstly, a blood test done by the patient on their own is inappropriate. A blood test should always be ordered by the physician or by a physician who has a specific thing that they are looking for, and which is why these large panels of testings have created very complicated scenarios unless they are very accurate tests of picking up a lot of false positives, like someone who has a very high total IgE. Normal IgE should be less than 150. If a person's Ig is, let's say, over 1000, which we see a lot in a country like India, because we have a lot of exposures because of which Ig can go up. Now, in this person, you'll have a lot of non-specific binding to the process in which the blood test is done. And because of that non-specific binding, as you said, they are eating rice, they're eating potatoes, and the test is positive. There are two ways to handle this. One, if you truly have a doubt that they may have an allergy, you have to eliminate the food for some period of time and then reintroduce it either in your presence, which would be an open challenge, or there are other protocols for it, and see if the person develops symptoms. Or you have to tell them that this does not have a clinical relevance to what you're going through. And that is where the experience and knowledge of an allergist comes in, to know based on what the person is going through, is that food even relevant to what they're going through. So if you come and tell me I have a rice allergy and I'm having allergic rhinitis, it has no bearing on it in most cases, 99% cases. But if you're having chronic hives, urticaria, and a rice allergy comes up, maybe, okay, 5% chance or 10% chance something may happen there. So first thing is explain to them about sensitization. A positive test is not an allergy. Second, explain to them there can be false positives because of a high total IG. So if you do a blood test without a total IG, it becomes very hard to interpret. You always need that along with it. And then lastly, recognize, as I said, there are bogus tests. They have figured out what the commonest allergies are. They just put it in any random combination of the reports and give it. We can't help it. Work has been done, but any allergist who has ever seen those reports knows that these haven't been done correctly. They've even been banned in certain states, but they still figure out ways to find local partners and continue doing what they are doing. Well, we can do only what we do properly. We cannot change the world. So, hope that answers your question. If there's still some clarity you need, please ask. Good.
Thank you, Dr. Roy.
Sure.
Yeah. So if any more queries, you can post on the chatbot, or you can email directly to Dr. Roy, or at contact JSPH. And I would request Bhavna ma'am to please give the closing remarks.
Thank you so much, sir. Again, wonderful presentation, wonderful efforts you have given to your PowerPoint presentation too. That's also great. And you always amaze me. That's the only one sentence. A very important message for all students that this is a very important a chapter for you to understand a public health issue, chronic disease, and there the public health message is that why this patient education is really, really important. How allergy identification, allergen, this identification and avoidance is important. I think this has given a very good message to you. Thank you so much, Dr. Roy. Thank you so much.
My pleasure, Dr. Bhavna, and a special thanks to Dr. Purohit, Dr. Anil Purohit,
Yeah.
for inviting me. He sees some of my posts, and there was a post I did for World Asthma Day, which happened earlier in May. And he said, you know what, Dr. Roy, this could be a presentation for our students. Why don't you do it? And that's where the idea came up of doing this lecture. So thanks to him for his vision and recognizing the importance of these things, and for the students who are hearing about it and are studying to take this message out, because I think public health is the way to address these things, because that's a very important access point for a large number of people to be impacted through public health, whether it is through legislation that is done, whether it is through healthcare services that are provided, whether it's through education that is done. It's a very, very critical thing. Definitely, our country is in need of it. So, thank you very much for what each one of you all are doing and are going to be doing in the future. Have a blessed night. Thank you very much.
I would suggest all students to follow Dr. Roy, because the way creatives are being done, this is kind of learning for us too. Very nice, sharing you are doing in your all Instagram posts, Twitter account, like even YouTube too. You should follow how these creatives are prepared and how learning can be done. Great job, sir. The creatives, whatever you are there in Twitter. Great job.
Thank you
Wonderful.
very much. Thank
Yeah.
you very much. Thank you very much for the kind words. Have a blessed night. Take care, everyone.
Thank you.
Okay,
Everyone.
bye-bye. Great.
Shubhratri.